I am Samuel Verkhovsky. I am with the Cross-Cultural Healthcare Program. We are a training and consulting organization, and our primary activity is the training of medical interpreters. We also provide cultural competency training, and we have a system, or network rather, of licensed agencies in 26 US states that teach our curriculum. And we have some other customized trainings and patient guides and things like that. One of the goals of the Cambia Grove is to reorient the discussion or reorient questions back to the individual patient. And I think that addressing social determinants of care, social determinants of health, is one very effective way to reorient attention and focus back to the individual, because every individual has their own social determinants of health.
Good evening. My name is Kachina Inman. I'm here representing Southwest Washington. So I am the Executive Director of the Healthy Living Collaborative of Southwest Washington. I work in Clark County, Cowlitz County, Skamania, and Wahkiakum. So 4 counties. We're a collaborative, so we work with over 50 organizations across that 4-county area. We're focused on creating healthy communities, and we really do this in 2 distinct ways, really looking at the ability to engage with the community and look at community-based prevention efforts, as well as always keeping our eye on the policy and systems levers.
Thanks. My name is Michael McKee, and I'm the Director of Health Services and Community Partnerships at International Community Health Services, which is a federally qualified health center. And there are acronyms for everything that I just said. Because it's a mouthful. The International Community Health Services has been around for about 42, 43 years. We started in the International District in Chinatown, and then expanded in the mid-90s to the Holly Park neighborhood in South Seattle, and in 2014, in large part thanks to an improving economy and the Affordable Care Act, expanded to Bellevue and Shoreline. And in between, we've opened up a school-based health center and also have a mobile dental clinic serving 10 Seattle schools and 2 Shoreline schools, as well as community partners during summers and other school breaks. And I'll save some of the other work that we do and who we serve for later.
My name is Rachel Ceballos, and I'm an assistant member at the Fred Hutchinson Cancer Research Center. I'm an assistant professor at the University of Washington. And my work is primarily in the Seattle area, Eastern Washington, and some in New Mexico State as well.
My name is Leanne Miyagawa, and I am assistant nurse manager of a program at Harborview Medical Center called Community House Calls, where we focus on the access of care for immigrant and refugee populations.
Well, I'm going to go into a little bit more detail about how our collaborative works, because that will help you understand the populations we serve. So for us, I mentioned that we do a lot of community-based prevention and engagement, and to date, that's really been centered around community health workers. Really, community health workers are lay public health workers, right? They're often members of the community. They speak the same language. They have similar shared experience. In Southwest Washington, we've trialed something a bit different in that we've looked at creating teams of community health workers, the natural helpers, natural leaders living in communities that were really experiencing significant health disparities. And we went through 90 hours of community health worker training together. So we built a team. We built on people's existing skills, knowledge, expertise of their communities. And now they're working in those neighborhoods. So we have a very strong focus in those 3 distinct neighborhoods. So they are volunteers. They are giving a ton of their time and energy. We thank them by giving them a $200 stipend. This was modeled after some work done in Salishan, housing authority in Tacoma. And it's been pretty phenomenal. So they're connecting their family, friends, and neighbors to resources in ways that often as professionals we can't do, right? Because they're next door, they're experiencing the same thing. They were there when the drive-by shooting happened, 3 days earlier, and their kids were in the backyard, right? They were there when the housing complex sold and, people were without homes. So shared experiences. And then they're working as a team, right? So bringing their expertise together to build that capacity. So really powerful, looking at bringing access to healthy foods to the neighborhood, walking groups, social connection opportunities. So anyways, I could go on and on all night long about all the incredible work they're doing, but huge focus there. But our key is how do we connect that back to bigger transformation, right? That neighborhood work is beautiful, but how do we get that back to the policy systems piece? So we have a policy committee that is part of our collaborative, and so we're looking at what are those policy issues that we want to tackle. We always, every year, have a local policy agenda. We weigh in on state policy. And we're looking at organizational policy. Our community health workers sit at the decision making with our executive directors from housing, education, the faith community, healthcare. So that's a little bit more detail about the communities that we're serving, but we do work across 4 counties and feel that a lot of our policy systems work that we embark in does have an impact across our 4-county area. So for us, there's a couple of really key areas of challenges to accessing healthcare. We have a huge gap in just folks that will accept Medicaid. So we have a lot of people that do not have access to healthcare, and to be seen by a doctor can take weeks upon weeks, and you can imagine how this impacts many, many facets of their life. So that's one critical issue. The other that has really, really come across all of our communities is affordable housing. So we butt up against Portland metro area. They're in an affordable housing crisis, and it is definitely started to impact Southwest Washington, all the way into our more rural communities. So we have a huge access to affordable housing. We have incredibly low inventory, rental inventory, and it's causing severe homelessness issues. And so I'm sure you can imagine how this is also deeply impacting healthcare and people's ability to access healthcare and take their medications and get to the doctor and all of those other pieces.
So our organization started in the International District historically by Filipino and Chinese activists who saw a need for healthcare access that was both culturally and linguistically available. And since that time, we've really evolved to serve as the nature of the immigration patterns and refugee patterns in the Puget Sound have continued to diversify. Our organization has continued to diversify. And we sort of maintain this ethic of our core mission is to ensure linguistically appropriate and culturally appropriate health care. And but not everybody we serve is a refugee or immigrant, but the definition of a federally qualified health center requires us to have our doors open to anybody and everybody who needs to have access to health care, regardless of their inability to pay, their insurance status, whether or not they're documented or undocumented, or any other status that you might consider for which people might be denied health care. We did choose the locations for our clinics, particularly for the South Seattle and as well as Bellevue and Shoreline, based on community needs assessments, where we were looking at establishing not just, we didn't want to just say, we have a clinic, you should come to us, but we also wanted to assess, well, where are our patients who we should naturally serve living? And where should we go? And so we had a long-term plan to expand to the east side as well as to the north end, and we continue to want to go south in King County, but because we were tracking from the census data where our immigrant and refugee and Asian and Pacific Islander populations living. And then I think I started to sort of track, like, what are the similarities? I guess transportation is, of course, a challenge for patients for accessing healthcare. I put culture and beliefs, and I think part of that is just we spent a lot of time trying to educate our patients on the value of having a relationship with a primary care provider and not waiting until it hurts so bad that you need to go to the emergency room, and really trying to understand that we have, even for our patients who are insured, our community health workers, we have a robust team of 11, report back that patients have this belief as, well, I don't want to go see the doctor because I want to save that position for somebody else who needs it, even though we're trying to say we need to know how to actually serve you if we don't know what you have or don't have. And I think the things that we need to know more about our patients is we're not, because we don't often collect some of the social determinants of health issues. We know some of our patients do have employment concerns, but they also, some of them have multiple employments. And so the barrier of access is managing work and time and the need to see a doctor. And then of course the issue of education and being able to, we don't know what kinds of education our patients have, and that actually would be helpful to start tracking, so it gets education and literacy in any language has a far more of an impact on health outcomes than actually seeing the doctor. So we would think that that would be helpful for us to think.
Overall, at the Fred Hutch Cancer Center, which has actually been around 40 years now this year, in Seattle, so that's a big celebration. But it's not just cancer that we work on. We actually work on infectious disease. We have a very large division that works on HIV. I myself work with diabetes as well as pesticides in addition to cancer. So we cover all of those topics. And we not only work in the basic sciences, but social sciences, as well as economic and policy level aspects. So the institution as itself runs the gamut, trying to cover all levels that affect social determinants of health. My work definitely do not want that stigma of the researcher who conducts research on a community as opposed to with the community. And we really try at every sense to bring the community aboard. One of the primary projects that I started in that area actually came out of a community request, which was to find community support for cancer survivors. There are no Spanish language programs, despite 70% of the population being Latino. There are no Spanish language programs in Central Washington, and we found out there's actually none here in the Puget Sound region as well, which was surprising. So we started with qualitative work, which is asking what are the needs of the community, what are the resources, doing an assessment. And then from that, I developed a 10-week social support group that is adapted both linguistically and culturally. And we ran that program as a pilot project out in Central Washington, and it went very, very well. We actually found some results. I wanted to say one of the things that I focus on is not the social determinants of health in the more traditional sense. I actually focus on the psychosocial aspect and the aspects of trust. And social support, and how those play into our health and our ability to access healthcare, willingness to access healthcare, how belief systems play into this. So these are all things that we address in the support group and try to bring an appropriate cultural perspective to each of those groups.
We serve immigrant and refugee health, refugees. And in 1994, this program, Community House Calls, was born out of a Robert Wood Johnson grant from 2 physicians at Harborview. And 2 years later, it became part of the mission of Harborview, because the mission is to serve the most vulnerable, of which that includes immigrant and refugee communities. And so we've continued to serve, and Harborview has taken on that financial role to provide this program, and 3 years ago we added on a piece of diabetic navigation where we are working with the Somali and the Latino community on self-management. The language and literacy of limited English proficient patients is clearly a challenge that we have. Cultural differences and how those work with the Western medical model is something that is a challenge. Past trauma is something that we see a lot with the immigrant refugees and is a challenge as well. The age, the majority of the patients that we see in the outpatient area are over 50 years old, so we're seeing very complex comorbidities with the populations there. And then also with that is sort of a generational issue, so you have many of the patients that we're seeing that are the immigrant refugees, their children may have been really young when they came here or they were born here, and so there are differences around the perceptions, the needs, and the requests from parent to child. Transportation is an issue. What we're finding, in 1994 when this program started, the patients that we served were much closer to the Harborview hub, and as affordable housing has changed that, we're seeing the migration further south, which really impacts transportation. Affordable housing was another one that was mentioned as well.
For us, it's both upstream and downstream. I think that's where we really get to the long-term sustainability, creating healthier communities, is when we're looking at both the upstream and downstream. As I mentioned, policy systems work is critical for us. So that looks at every level. So let me give a quick example around affordable housing. We worked with the Housing Authority. They're a key partner. They sit on our leadership. They saw us as a collaborative that was deeply connected to the community. So they went to us and asked us to help assess the community need on how to prioritize the Section 8 vouchers, which is an incredible resource for many communities, as you know. So that's one way that we can impact how an organization changes how they provide services. And then locally, we're looking at local policy issues. So right now, we're working really hard on an affordable housing campaign in Vancouver. It's new for us to be actually endorsing a campaign and donating to a campaign, but we're really proud of it. And we're doing it because our community health workers said, this is where we start. We can't even talk about access to healthy foods. We can't talk about access to care if we do not have a safe and stable home. And that goes to the same level when we look at our state agenda. So when we look at selecting our state agenda, affordable housing was key. It was number one. We were weighing in on multiple issues, and I anticipate it will look the same in the coming session.
I think where I think we're finding ourselves is just needing to be a little bit more creative. And the best way I can do this is to tell a story. And so, like, recently we had a provider who sent an email to my colleague, the chief operating officer, and myself, and the CEO, and basically said, I had a patient come in today. She hadn't eaten for 48 hours, and we were trying to talk to her about managing her diabetes. I went to the office and I printed all these things off the computer about the available food banks in the Seattle, King County area, and I scrambled around my office for some nuts and some goldfish from my personal stash to give to my patient. What do you think about having food available for our patients? And we were like, good idea. And then it was sort of like, well, we don't need to be a food bank, so let's partner with people who are in the business of being a food bank. And so we went to one of our community partners, Asian Counseling Referral Service, who runs food banks with culturally appropriate foods, and we said, hey, what do you think about us having just like a bag or two in each of our clinics, so that when a patient needs it, we can give it to them. They're like, great idea. And so it's like those things that, if you just stop and think about what you can do, it's sometimes very simple interventions, but are very meaningful for helping patients get the service they need. Because, like I said, health happens outside of the four walls of that exam room, and health choices are made outside of those exam rooms that are impacted by social determinants of health?
Doing in terms of downstream, we are working on another issue that we find is the whole medication refill issue for our patients, and so we've worked and collaborated with our pharmacy to have a dedicated line for limited English proficient patients so that it can be easier for them to order their own medications and empower them in that way. We also streamlined the financial assistance program. So at Harborview, we used to call it charity care, and we have changed that to call it financial assistance. And with all of our affiliates, there was a different process that patients had to use. And so what a great idea, but let's make it all one application and have it the same. So we've completed that. We have, as you know, in the research, limited English proficient patients have much less time with the medical staff at the bedside in terms of updating them on information. So the staff advocates for the patients and families to have more time with the healthcare team at the bedside, whether that be one-to-ones during the rounds or organized family conferences. Improved transportation, Michael talked about that. We have encouraged and support and advocate for patients to do Orca Lift. We have HopeLink if they're financially eligible for taxis to pick them up, to take them to and from their appointments, as well as Metro. One of the other things that was a downstream example is in the Somali community, we were hearing from a lot of the women patients that they had a lot of headaches and pain and discomforts and fatigue. And so my predecessor, Bria Tchaikovsky-Louis, developed, and it continues, along with Sama Musa, a weekly wellness group that's open to the community for Somali women called Darial, which means wellness in Somali. So it's an opportunity for women to get together, do yoga, have massage, and most importantly, socialize. So that's something else that's been very successful. Some more upstream efforts. One of the things that we require all of our caseworker, cultural mediator, and diabetic navigators to do is to have set aside time for the community work. And so that time is allocated to address issues that they have facing their communities. So for example, we partner with ACRS, and one of our caseworker cultural mediators does a weekly Vietnamese senior gathering where they have over 90 seniors every week on Fridays, and they get together, socialize, they have lunch, they have a health education topic. Or we have Jen in the Khmer community who does a monthly health forum for the Cambodian community, of which they've identified what's important for them. We are also going to be meeting with our social work department to start a pilot looking at improving connections to patients with community-based health resources, so stay tuned for that. And we've partnered, the diabetic program has partnered with the state and federal government around the WIC program and getting monies for farmers markets so that our diabetic patients can go and purchase at the farmers market healthy vegetable and fruit choices.
I used to work for a nonprofit called Health Leads, which you may be familiar with, that their model is to staff a help desk in the provider setting with volunteers that then help refer patients to community resources, help them fill out the forms, things like that. They made the tough decision a couple of years ago to stop following up on referrals for housing because the success rates were just so low that we just kind of gave up. You know, at the same time, we realized that that's one of the largest indicators of future health. So how do you sort of balance the trade-off between handing a bag of food, which you can do every time, versus trying to fight for housing for somebody, which has a much bigger impact on their lives, but you know, you feel like you're beating your head against a wall a lot. How do you guys think through where to spend your resources?
So that's where I think the collaboration piece comes in. For us, we are all about our partners. We are nothing without our organizational partners. So it's getting down to how do we plan together, right? How do we make those hard decisions as a community? So one of the things that we are launching right now, it's in the works, is as healthcare transformation happens and as we're starting to do work differently, there's data needs, and that's a key piece. We always want to look at evidence and the data to help guide our choices. So right now, Washington State and the Healthcare Authority are looking at an analysis that looks at claims data. We're saying that's important, but we also want to look at housing data. We want to look at education data. We want to look at criminal justice data because we think they're all linked. So we're in the process of looking at those shared data agreements and how we plan together. And a key piece of that will always be the key core information from our community health workers to what is happening in the community, what's not happening in the community. So that will be a hard piece of, and I think someone was going to talk about the PREPARE.
So PREPARE stands for the protocol for responding to and assessing patients' assets, risks, and experiences. Whew, I got it right. But the PREPARE model is intended to standardize that. And what excited me about it is that it is getting traction nationally among federally qualified health centers. And I think that, I don't want to put the cart before the horse, but I know that ICHS is assessing our capacity to do this and to be a part of that. Because what I see happening is that in true place-based social determinant of health-driven healthcare transformation and delivery systems, what social determinant of health we address in our Chinatown International District clinic might be different than what social determinant of health data is coming out of our Shoreline clinic. And so we would want to be flexible enough as an organization to not say, well, this is the social determinant of health issue we're going to address, but to understand that, well, our data says this intervention's needed here, but a different intervention is needed somewhere else, and we should be able to respond to that need. And then I think the other piece that's exciting about this is that, and if we think about partnerships, the ability to then share that data after it's collected, if everyone's collecting it in the same way, then we have comparable data. And federally qualified health centers are accustomed to this because we participate in something that's called the Uniform Data System, where we all collect the same data that's sent to the federal government, that so that if we were all doing this around social determinants of health and we serve across the country a safety net population that is very unique, and if we could tell their story and understand the differences and the nuances from, even from county to county or city to city or state to state, I think it's going to be very helpful in identifying where should we put our resources. And I think the easiest thing for us to do probably is, I'm sure that Cambria Grove has contact information for some of the participants, because I could send out a link rather than try to tell you one today. But I mean, the NAC website has a very comprehensive summary of the PREPARE project, and the social determinants of health across the country and through NAC and federally qualified health centers was a key and core component of the messaging at their conference. And so I think the time is now to figure out how do we do that, and with the partnerships as well, as we need to be able to have this ability to collect the data across multiple electronic health record platforms, and that's not an easy thing when you're an FQHC. We know our electronic health record, but we don't know anybody else's. And so that's where we need some of those innovators around technology folks who understand how can we create these templates so that they can speak to each other and the data can be shared and we can sort of tell the story.
Okay, so Kachina, I'll start with you because you were the first panelist. And I was very interested in your description of your community health workers. One question that I have is, so they get a $200 stipend and they're volunteers. do you see, have they moved? And is there any potential for them to have more professional growth with salaries in the healthcare system that they are now understanding so well?
Thank you for asking that question. Yes, so with little financial resources to get this off the ground, that's where we were able to start, and we're incredibly proud and excited by the work that our community health workers have done. So it's really interesting. I don't know if you've watched and looked at the Ceballos community health worker model in Tacoma, but we've modeled much of our work after that. It's in a housing authority setting, and we're looking at in a community setting. So that too is a stipend. But yes, we are seeing huge, our hope is to build out community health worker activities in multi-sector. So the exciting piece, going back to the collaboration component, is our different organizational partners are seeing the value of this. So our federally qualified health clinics are saying, yes, we need more of this. Our education partners are doing the same. We have a permanent supportive housing center that houses 30 of some of our highest need communities. They're saying we need a community health worker. So we have a lot of grants in motion right now, crossing our fingers to build that out, because yes, we need livable wage community health worker jobs. And that is a goal. The stipend volunteer piece is also a beautiful platform for some. We have folks that are retired, and this is their way that they love to give back. We have moms with small children, and this is a way to continue to build their skills and abilities. We've had a number of community health workers go back to school this year. So yes, that is our goal, and I can't wait to say what we're doing in 3 years from now, but we're starting small.